Guys, we're finally here. Welcome to the first episode of OrthTeam Unplugged. I'm really excited about where we're going with it. And John, you and I have been talking about this for a long time. My work at PhysiGrip is all about inspiring growth and bringing people together. So this really aligns with my passion. So from your perspective, tell me about your mission for this.
Thanks, Andy. Yeah, equally, excited to get this off the ground, and thanks for your support and getting this started. I know we have spoken about it for a long time, and for me, it's about getting good information out to the people we work closely with in terms of our referrers, physiotherapists, sports clubs. We communicate frequently by letters and WhatsApp, and it's a really useful medium to share what we're doing at OrthTeam in terms of the expansion, the new clinical services, the talented colleagues that we work with on a day-to-day basis, the multidisciplinary work that we do. And it's great to be able to inform our colleagues so that they can get the best out of us and the best out of OrthTeam for their patients and for our mutual patients.
So, Jim, there's a lot of acronyms within our field. SEM, what is it?
With sport and exercise medicine, there's quite a few common misconceptions, misunderstandings. When I'm speaking to someone new and they're asking me what I do, then often you need to try and go through it a little bit more. And that's true in quite a lot of new emerging areas, right? So sport and exercise medicine is a relatively new NHS specialty, a small specialty as well. There's just over 150 consultants on the GMC register. Myself and John are involved in some work with the faculty, hopefully trying to form a new college of sport, exercise and musculoskeletal medicine. And that musculoskeletal bit we feel is a really positive addition. And if you look on any of the faculty information and websites, it's quite clearly split into three strands of our work. So there's team care, which is the bit that often people assume and focus on. So that's looking after, elite professional athletes. There's also musculoskeletal medicine and also exercise medicine. So they're the three common strands that someone working in sport and exercise medicine would be spending their time doing.
Right. And then, so, a typical day at OrthTeam, then what would that look like for you? Who would you be seeing?
Yeah, I mean, it's interesting now because we've got 5 consultants in sport and exercise medicine at OrthTeam Centre. And I think if you looked at any of our actual practice, it would be quite different. The most common one for me personally is just seeing someone with a musculoskeletal condition, be that pain, injury. And that probably makes up about 70 to 80% of my working practice. And that could be something that's sustained through just normal life, occupation, sometimes sport as well. And then probably about 20% or so is made up of people who are either professional athletes or in that sub-elite category where they, I would say, are doing a job but positively identify as being an athlete in a particular sport. So that's the type of person who might say, I'm a triathlete or a high rocks athlete, physical activity and exercise is a really, really particularly important part of their life, I would say. So that tends to be my breakdown. But again, it is different from each person to person, I would say.
John, how about you then?
Yeah, I think my practice has probably changed over the last 5 or 6 years since working at OrthTeam, actually. And similar to Jim, I see a lot of general musculoskeletal medicine in children and adults across the age span. But probably a higher percentage of my patient cohort now are, elite or professional athletes from a range of different sports, football, rugby, track and field, whatever. And I see any given day is really varied generally. I could be seeing like a tendinopathy, a stress fracture, an athlete with relative energy deficiency in sport, or concussion, or sometimes fatigue with unknown cause, or cardiac or respiratory symptoms related to exercise. Or it might be a person who's been sedentary and has low back pain and sciatica, and they're overweight, and we need to consider lifestyle factors that are relevant to their presentation and use motivational interviewing techniques to help address their physical inactivity. So it can be very varied from one day to the next, which is what I love about my job and what I do.
Yeah, John, you've been involved in this from the start at OrthTeam. What was the vision when OrthTeam was created? It's quite a unique setup from what I see in the industry. What was the vision?
Yeah, so I was invited to join OrthTeam about 10 years ago. And at that time, it was a group of orthopedic surgeons who had come together to do CPD educational events for physiotherapists and GP colleagues. And there was a vision that we would come together as a group of clinicians to deliver collaborative care for patients in a bespoke centre. So instead of it just being an educational group of consultants, that we would actually work together in a building with the whole remit of diagnostics, radiologists, from like upper limb, lower limb, spinal surgeons, sport and exercise medicine doctors, pain management, rheumatology, and that was the vision. And there was we have a joint venture with Spire Manchester Hospital, who have supported us since we opened in September 2019, and it's been a fantastic way to work, a very collaborative, multidisciplinary way of working, and I think that's been a real point of difference for me as a clinician, in that I feel I can deliver better care for patients, athletes who I see, because I've got trusted colleagues from orthopedics, radiology, pain medicine, rheumatology, people who are leaders in their field, who I can very quickly tap into that expertise on the phone, or they're maybe working in the room next door. And we have specific multidisciplinary clinics there for radiology, sports medicine, spinal MDTs, hip and groin MDT, there's knee MDT. So it's much more collaborative, particularly for complex cases. It means, previously I would have worked in quite a siloed way, whereas now, I've got great colleagues like Jim and Andy Dunn and Waqar Bhatti and David White, Rebecca. There's loads of people who I work with who I can lean on for advice and support in difficult cases. And we do that every day.
You obviously generated a massive amount of interest. There's huge respect for the caliber of people that you've got at the institution there. And at the recent event, there was over 400 people where it was the OrthTeam conference, which was brilliant. I really enjoyed it. And so from your side, Jim, because I'm out in the field all the time speaking to clinics, and there's so much stuff, as you're alluding to here, there's so many different things that people can see you guys for. What if you were communicating to people that didn't know much about OrthTeam? What's the best way to engage with you guys as a referrer from a physiotherapy practice?
Probably two things from them online there. It might be someone who might be an established referrer, I would say. With those people, often, most good to both of us, but often you might have a main contact with a lead physiotherapist in a practice, for example, and they might send you cases. And often you obviously refer back to them with a letter afterwards, but there might be a phone call, WhatsApp communication if it's, particularly complex, that type of thing. I would say for new referrers who aren't used to sending cases to us, then I'd be more than willing to speak on the phone about a case just to see if it would be appropriate or not, because it's the same thing if it's the first time they might be using our service where they may have referred to somebody else in the past. And I think to try and build a service and make sure that it's the right, the right path for the patient primarily. I didn't more willing to speak on the phone or email.
You've both mentioned of the numerous communication methods there are now. I experience it: WhatsApp, email, call, social media, all of these things. How do you manage it? Like you've got multiple roles. You've got a leading position at UKSI as well. So how do you do it?
I mean, it's important, I think, just to fit it into the working day. And we were talking before it's a way of building, a practice and, building the service that we're trying to offer at OrthTeam Centre as a sport and exercise medicine group. So I think it's really, really important that you build personal relationships with key referrers. And within that, you start to build trust in us as a group of clinicians, and therefore likely that, say, a physiotherapist who's referring a case in knows that it's the correct thing to do. It's appropriate for the patient as well. And then they're going to get timely feedback from us as a consultant and actually work together on it as well. That's the thing. That's what I've definitely learned from my UK Sports Institute work is the collaborative nature of actually working and sharing problems, within OrthTeam Centre, like John was saying before, but actually really importantly that we do that with referrers in as well. So it's not just come in and then it's, you just keep all the information to yourself. So working together, I think, is really important.
You mentioned a few of the names there, Andy, Waqar, and some of your other colleagues, John. What is the conduit? Because the relationship may be with one of those guys, with the referrers, or with you. So how do you handle that if you've got people referring in from a radiology perspective or an SEM? If you've got the relationship, how do you work that internally from the MDT side?
So if the referral comes through to me, for example, and that might be direct communication from a referrer, and people will have different communication preferences, whether WhatsApp or whether a voice message or whether it's an email or whether it's a formal letter, which are all great. Then I will facilitate diagnostics and imaging depending on what the clinical suspicion and query is. And it may mean sometimes where it's time sensitive, organising a scan, for example, before I even see the athlete or patient, but usually we will see them for a clinical consultation first. The MDT sort of service is slightly different. So it may be that somebody's referred in from a club, for example, and they've got a complex injury. And then at that point, it may be that one of the radiologists says, I know we've got particular expertise in this area, and that might be sport and exercise medicine, or it might be orthopedic expertise because of the nature of the injury. You know, for example, if it's a tendinopathy or a stress fracture, or I see a lot of power stress fractures in the lumbar spine, for example. You know, there are particular areas of expertise that the radiologists are actually very clued into knowing who has the particular skills and experience to deal with that pathology. So there's a lot of, because we speak with the radiologists on a daily basis about cases, they have a very good understanding as to if the referral comes directly to them, they can tell the referrer for that diagnostic imaging, usually, you should see Jim for that particular problem, or you might want to see one of the specific knee surgeons if it's an anterior knee issue, or if it's a hip impingement, you know, it might be to see Max Fehily. It depends on the pathologies, but a lot of the stuff that comes to me, like I think our particular skill set in sport and exercise medicine is making an accurate diagnosis quickly and facilitating the further rehabilitation and care of that patient or athlete. And that might mean refer back to physiotherapy. Often that's the route. It might mean an intervention from a pain management perspective, or an injection. It might mean referral onto orthopedics. And it might mean pulling in other sort of allied health professional expertise, which could be clinical psychology or sports nutrition or sports science, strength and conditioning type input or things like that. So there's no onus on us to make an early diagnosis and then to refer on appropriately, and then to manage that team of clinicians who are involved in the care of that patient. And we do that in sport all the time, in elite sport. We used to work as part of an MDT. But the great thing about working at OrthTeam is we can do that for the general population in the same way as we do for an Olympic level athlete. And I feel strongly that gives them a very high level of care, which is a great way to practice medicine.
Yeah, it is quite a unique way of doing things in the private sector. And how big is the distance? Like, where do your patients come from?
When I first started doing private practice, it tends to be more isolated to the Northwest, and then it still tends to be that, but you do have people further afield. You know, I've had patients as recently, Scotland, Isle of Man. I know John's seen some people internationally because it was 20 minutes away from the airport as well. So actually the reach of the OrthTeam Centre practice is much, much wider than perhaps people might envisage. So we do get patients travelling to see us. And I think that alludes to, that we've got 40 consultants there at OrthTeam Centre who are all like really expert in their particular fields. And I think people recognise that and are willing to travel to have the right opinion for their condition. So.
And I think it's really interesting. Like, I've seen you as a patient, my mum's seen you as a patient, and so it's a real diverse set of clients that you can see there. Because as soon as you put sports at the front of anything in my work, it's that people do assume, right, it's athletes, it's the Premier League or whatever else it is, whereas actually it's miles more diverse than that we've touched on. So, like, from your side, then, roughly, you've mentioned about elite teams that you work with, but like, what's your breakdown of the type of work that you see?
I think my practice now, in terms of sort of elite sport, is in the region of 50 to 60%, and then most of the rest, probably about 20 to 30%, is general musculoskeletal practice, and that's in children and adults, and then I see other sort of medical type problems like concussion. I see 2 or 3 cases a week of that, and occasionally cardiac problems related to sport and exercise. I see more virtual consultations now from, to Jim's point, from around the country. My big interest is in endurance sport, because I've worked with British Athletics and British Triathlon, and I've seen a lot of endurance athletes over the years. And I tend to see more endurance athletes with stress fractures or energy deficiency type issues, or overtraining syndrome and things like that there. So I see more sort of referrals from around the country, and some of that is virtual. But then more locally in the Northwest, it could be, sort of weekend warrior, sort of serious sports person who has picked up an injury playing rugby or football at the weekend, and it's not resolving. I think the other point of difference to sport and exercise medicine, what Jim and I see, is, more complex injuries. And I think that's where we can add value. Physiotherapist colleagues who refer to us regularly will know usually when something is a bit more complicated and needs an MRI scan, for example, or needs, more rapid diagnosis if it's a high risk type scenario, and when to lean on our expertise where it's sort of multifactorial cause of injury, and where there might be, metabolic issues or other medical issues at play. But I love seeing people across the spectrum. And I know sometimes patients come in and say, "Oh, I'm not an athlete," but I think there's an athlete in everybody. I think our job is to try and help motivate and get people as physically active as we possibly can. And whether that's somebody in their 80s who wants to be able to walk, down to the village on a regular basis, or somebody wants to play, rugby for their school, at the weekend. So it's very varied, and that's the way I want to. I love what I do, and I think I probably wouldn't want to work anymore in a specific sport, because I enjoy the diversity of what I do at the minute.
Just to qualify, my mum's not in her 80s yet, so John wasn't referring to her.
No, definitely not. No, but it was lovely to meet her.
So with the guys from OrthTeam, they do work at the highest level of sport, and sadly, Jim has had to head off to deal with something urgently. That is the nature of how it is. So I've got the pleasure of having John here with me one-on-one. So let's get back into it. So John, I think it's a massively exciting space in the private healthcare world at the moment. I've seen massive change in the last few years, since COVID, but even before that as well. Historically, 80% of my work at PhysiGrip was with the NHS, whereas now it's 80% is with the private, and then the other 20% is roughly elite sports. So what role do you see OrthTeam Centre playing within the healthcare landscape?
Yeah, certainly been a massive change during my career in terms of musculoskeletal medicine and sport and exercise medicine. And I worked in the NHS for 25 years and have friends and colleagues who work in both in sport and exercise medicine and a lot of other specialties in the NHS. I think for us at OrthTeam, the ability to turn things around very quickly. And so the type of medicine that I currently practice, where we see patients and athletes who sometimes require a diagnosis very quickly, which may be MRI scanning and access to that. Particularly if it's your livelihood, if you're a professional athlete, you need to know what the diagnosis is and you need a treatment plan very quickly. So we can turn things around very quickly, which we can't do in the NHS to that degree. And I think reducing waiting times, like obviously for a lot of orthopedic musculoskeletal complaints, there are significant waiting times in the NHS, unfortunately, at the minute. And the ability to investigate people quickly can have a big impact on how long somebody's off work or how long somebody's off school, or, some of the specialist services that we have around concussion, for example, where we can coordinate multidisciplinary care. I think that's a gold standard really in terms of what we can deliver within that setting that we have at OrthTeam. And, I think it also provides a model for how we can develop services within the NHS for the wider population. And certainly, the work I do with our faculty and future College of Sport and Exercise Medicine is very much focused on how we develop services for the NHS, so that the population health is impacted by the work that we do. More and more companies, I guess, will invest in private medical insurance for their employees, because they understand the value add of being able to access high quality care quickly, and in terms of productivity and absenteeism. But for sport and exercise medicine, being able to diagnose things quickly has a significant impact on people with back pain and sciatica, one of the commonest problems that a GP will see, for example. So it's a great, I feel very privileged to be able to work in that environment where I can get an MRI scan on the same day, and I can turn that around within, get a report back and provide rehabilitation advice around what an accurate diagnosis is. And I haven't worked in the NHS for a long time. I understand also the challenges there are in that environment. And I'm still passionate about supporting that through the work that we do in training our registrars and doctors and resident doctors who are coming through training, and through the work we do with our faculty in terms of creating more NHS sport and exercise medicine jobs.
Yeah, and I was interested what you said about the college there, and just talk to me about how that happened and what the outputs of that opening are going to be.
So we are in the final stages. I've been involved with our Faculty of Sport and Exercise Medicine over the last 3 years as treasurer, and we are coming together with BASM, the British Association of Sport and Exercise Medicine, to form a College of Sport and Exercise Medicine, and hopefully a Royal College of Sport and Exercise. Sorry, the new title will be Sport, Exercise and Musculoskeletal Medicine, to reflect the three main streams of what we do. So there's team care, which, as Jim said earlier, is to do with sports and providing care to the athletic population. There is the musculoskeletal medicine, which is a very large percentage of what we do on a day-to-day. And then there's the exercise medicine and physical activity space, and how we help people who have chronic disease, for example, whether it's cancer or cardiovascular disease or dementia or depression, osteoporosis, people with chronic diseases, and how we prescribe exercise appropriately for complex medical conditions, but also how we address physical inactivity as a public health burden, and how we work with, government and public health departments, and how we work even on an individual basis with patients sitting in front of us in terms of motivating and behavioural change techniques to support people as they become more physically active, because we know the massive impact that has on their risk of multiple diseases.
Yeah, I mean, that sounds amazing. And I think it's so great to see that there's more emphasis being put on how important it is to be fit, to be healthy, to be active, and to keep yourself in good shape. So not just only from a physical standpoint, but from a mental standpoint as well. So that's really exciting to hear that. So
yeah, I think that is the future of healthcare. We can't keep delivering reactive healthcare, and I think we have to look at how we prevent, things like obesity, diabetes, cardiovascular disease is the biggest killer in the Western world, biggest cause of morbidity and mortality. So, the evidence base is very strongly there about the benefits of exercise and physical activity in terms of both primary prevention and secondary prevention, and helping to manage a lot of these conditions. And really strong evidence about the benefits of exercise for people with cancer, for example. And we have a key role in that as sport and exercise medicine physicians to prescribe exercise at an appropriate dose, if you like, in terms of medication, appropriate intensity, frequency, volume, types of exercise for people with a range of musculoskeletal complaints, but also medical comorbidities. And obviously, there's medication around weight loss that is changing the landscape at the moment as well. And that is having a big impact to some of the patients we see with knee or hip osteoarthritis and who are overweight, and how we can use both medication but also lifestyle changes in terms of diet and exercise to optimize how we all function. So I know it's a really exciting time for our specialty, I think, to work with people on how they, you get one body to last you a lifetime. And I'm sure you're familiar with that saying, if you had one car that had to last you a lifetime, how well would you look after it? That rings really true for me. And I every patient I see, we try to include the, particularly for the non-athletic population, the exercise component and how they can be more physically active to protect their longer term health, and what that looks like for them on an individual basis from a goal setting point of view.
No, I think that's brilliant. I think I'm all about how do we drive value for healthcare professionals and the whole industry, and just in that education piece. So yeah, well done with that. I'm looking forward to hearing more about that. And I'm interested in both you and Jim have worked at the highest level of sports. You're still active in that space. So what do you take from all the time that you've worked in sport, and how do you bring it into the work you do at OrthTeam?
Yeah, I feel very privileged in the work that I've done at British Athletics, British Triathlon over the years, but more recently at British Athletics, working at the Olympics last year and the last few World Championships with my great friend and colleague James Brown. And it's there are some amazing individuals and athletes who you get to work with, and that's professionally, it's very exciting to be in that environment, and it's often to see those athletes through their career, and we often see them as doctors at some of the low points, whether it's physical health problems or mental health problems, and then to see them perform and compete on an Olympic stage is incredibly rewarding as a doctor. I guess what I take away from that, into my day-to-day practice, it is the work with Team GB and with British Athletics. It's very multidisciplinary, both from a performance staff, coaching staff, medicine and science staff, physios, doctors, sports scientists, and I feel I can pull on the experiences and also the expertise of individuals to improve the care of whatever person is sitting in front of me, whether it's somebody who's looking to do a marathon, or somebody who's maybe got some nutritional deficiencies as a teenager. So that's been a great benefit to me, and be able to pick up the phone to people I work with in elite sports and say, I've got a difficult scenario, what do you think? And you'll have a PhD scientist who will give you absolutely chapter and verse on what the latest evidence base is. So it's great to be able to tap into that expertise.
Yeah, no, it's incredible. It's even more than I was thinking in terms of all the stuff that's going on at OrthTeam. So it's great. So as a take-home message for people that you engage with, whether it's a physiotherapist that's going to refer into you or a team, like what would your suggestions be for how they can interact with you guys at OrthTeam?
For me personally, I'm very fortunate. I've got a great practice manager, Susie Wright, and I've worked with Susie for 13 years now. And Susie's telephone seems to always be on. She's a workaholic. She loves her job, and I'm very lucky to work with her. Her telephone number and email address is on our website, and she's very responsive. And consistently every day, I get patients telling me how fantastic is Susie, and so she is a great person. She's very patient-centered, very caring, and gets things done. And that's a massive part of our job, is the administrative side of it. For OrthTeam generally, particularly for elite sport, we have an elite sport hotline, mobile phone number, which my colleague Emma Jarrett is the main person who will facilitate imaging, whether it's MRI scans, X-rays, ultrasound scans, injections. So Emma does a fantastic job for us, and that's a single mobile number. And the feedback from that has been really positive for clubs. And, often a physio or a doctor needs to get a scan done yesterday because there's pressure on them to have a clear diagnosis. And we're very lucky to have Emma, who's facilitating that and providing that sort of concierge type service.
Brilliant. Great. And then one final question, like you mentioned some of the sports side there. The teams nowadays have got massive medical infrastructure. How do you work with those teams?
Yeah, it's a good question. It probably varies depending on the club and the level of sport. And so, for example, in NGB type sport, Olympic sport, Paralympic sport, often patients will be referred into me by their doctor within the sport, maybe for a specific opinion, or because I'm based in Manchester and the athlete's based in Manchester and the doctor's based down south. So there are scenarios where on the world-class programme for Olympic sport and Paralympic sport, athletes have access to insurance through the athlete medical scheme, and then they'll be referred into me for an opinion, and I'll do a consultation as I would with any other athletes, and then feedback to the medical team as to the diagnosis and the proposed management. And that's often picking up the phone to the doctor or the physiotherapist within that sport. The other sort of common referrals that I get are from football clubs and rugby clubs. Rugby clubs, more commonly things like complex groin pain, osteitis pubis, adductor-related groin pain, inguinal-related groin pain, where there's different there's multiple different possible diagnoses, and it's more difficult to make an accurate diagnosis. So we involve radiology and MRI scans and ultrasound scans, but also hip surgical colleagues, hernia surgical colleagues as part of that diagnostic process. So the other common sort of referrals from rugby, for example, or concussion. In football, it might be for an independent opinion from a club doctor or a physiotherapist about a complex case where they just want somebody to take some time for an hour and a half and to sort of work the case because they're under a lot of pressure time-wise. And I think in Premiership clubs, they have got more resource, but maybe in some of the lower League 1, League 2 clubs where they don't have the same amount of medical resource, they will lean on us as sport and exercise medicine doctors for assistance with more complex cases in terms of diagnosis and rehabilitation and management plans. We're there to support the medicine and science team, whatever that looks like within individual sports, and these are friends and colleagues and people who we've worked with for years, and hopefully we can add value wherever possible. And I think it's really important that we understand the pressures that they're under, because I know, having worked in sport, people want things done yesterday, and there's often a bit of tension between performance staff and coaching staff and medical staff. Medical staff are protecting the health and welfare of the athlete, as they rightly should. Performance staff want them back on the pitch, this Saturday, and that can often cause tension. And hopefully we can provide independent, objective opinions for some of these more difficult cases where, ethics and medical legal aspects come into play.
I know you won't say it, but the feedback of my many good friends in the industry, in sports teams or clinics, is just not only how knowledgeable you are, but also how nice, accommodating and kind in the treatments. And that goes for my mum as well. So I think that's a massive part of it, is you're such a person-centered treatment and the way you do things. So yeah, thank you for doing that for my mum.
That's very kind, Andy. That's I think that's a really nice feedback, and I really appreciate that. I certainly, I think my colleagues who I work with at the OrthTeam Centre, we all work hard to try and give the highest level of care that we can. We understand that, patients and athletes who are sitting in front of us, there's a lot at stake every day. And I feel that I want to do my best for every patient that comes through the door, because it, allows them to live their best life. And it's a real privilege and very rewarding job that we do. And I'm supported by a great team of colleagues from the other consultants I work with, but also the admin staff, the radiology staff, the management staff at OrthTeam. So we've got a great team there, and it's a great great morale, and we had our Christmas do recently, and it was great to see everybody out, enjoying themselves, because we work hard, but they were playing hard that night as well.
So that concludes the first episode of OrthTeam Unplugged. I've absolutely loved chatting with Dr. John Rogers and Dr. Jim Kerss when he was here, and we're looking forward to the next one. So please comment, engage with us. We want to hear from you. It's all about collaboration with the community. So we're looking forward to seeing you the next time.